Radiation oncology. It's a field of medicine few folks know about. Unless you've had cancer, you might not even know what this specialty entails. And it's not a new form of treatment. In fact, the use of radiation to treat cancers began in the late 19th century. It's been around for a long, long time. Radiation is one of those phenomenon that can be both dangerous and healing. This is a paradox worthy of exploring. Since this modality can be part of the treatment of female pelvic and breast cancers, I wanted all of us to have a better understanding of this type of treatment after my conversation today. Welcome, I'm your host and creator, Dr. Amy Novatt. From both sides of the speculum, we are here to investigate what it means to be a healer and to be healed. Please send your comments to comments@radiofreerhinecliffe.org and share the show with your friends and family. Go to your phones right now while listening and give us 5 stars. And if you have any questions for me, write to GynoCurious@gmail.com. So today's guest is Dr. Beth Tapen. Beth is a radiation oncologist now practicing in Northern California. Beth's schooling and training including medical school at the University of Medicine and Dentistry of New Jersey, her internship at St. Joseph's Hospital Medical Center in Phoenix, Arizona, and the remainder of her residency at California Pacific Medical Center in San Francisco. Beth, welcome to the show.
Thank you, Amy. It's good to be here and good to be talking to you.
Yes, and you too. So I like to start GynoCurious conversations with our arcs, professional and personal arcs. Like, how did you decide on medicine and why radiation oncology? That's not a common choice.
No. So my arc was probably a bit more common, but totally crystallized one day, biology class. Another student's father was a gynecologist, and she presented the concept of a teratoma that her dad was telling her about. And I had an awesome 10th grade biology teacher. I always liked sciences and was much better at it than English and literature. And at that day, I just remember thinking, that's what I'm going to do. I'm going to be a doctor. That is so cool that this can happen in the body. So that's how I went into medicine. And then finding radiation oncology was difficult. Most people, as you know, get through medical school and will never have touched radiation oncology, rotated through, even barely heard about it. So after my internship, I was actually at a crossroads. I was about to start a general surgery residency up in Washington, in Seattle. And I would have had to separate from my husband for a couple of years on a very low budget. And the director of my internship program was very frank with me about the statistics of separating, both being on call every third night. And I was at a hospital that did not have a surgery residency, but of course they had plenty of general surgeons who I spent as much time as possible with. And they all said to me, the best part of being a general surgeon was residency. By the time they got to private practice, all the good cases went to the specialists, the colorectal surgeon. We didn't have breast surgeons back then, but the thoracic surgeon. And that they all would just have stayed in residency, which meant you either had to stay in academics or you had to specialize. And I really couldn't find a surgical subspecialty at that time that I had liked. If I had a do-over, I probably would have considered gyne-onc or breast surgery. I like taking care of women, but breast surgery was really just evolving at that time. And I had a tricky run-in with gynecology that at my medical school that made me uncomfortable with that field. So I said, okay, what's next? So I made a list of all the specialties I didn't know anything about and landed in radiation oncology. It was a great fit. Anatomic. And for me, what I didn't realize about my personality, I get to spend a lot of time with patients. I don't have to be 15 minutes, 15 minutes, 15 minutes. And that fits well.
Oh, that's very interesting. Yeah. So I don't know whether you're willing to share what that quote run-in with gynecology was. I don't know if you're talking about a personal situation or a professional one. Are you willing to share that?
Yeah, it was the residency program at my medical school, not the residency program. When we rotated through OBGYN, it was just couldn't have been more misogynistic.
Ah, yes.
And I mean, even men were appalled. And I just felt like it was such a negative impression. I never wanted to be around people practicing and caring for people that they viewed so inferior or not worthy of care. And it was tough because my mother was a professional and I thought we had come so far. And I was really shocked. That was late 80s. And I remember it was really hard. And I remember thinking, yeah, it put a negative turn on it.
Yeah, it's remarkable how many clinicians I speak to refer to these very significant moments
Hmm.
in their trajectories that either crystallize decisions or, well, crystallize decisions to do a profession or not to do a profession. And yeah, unfortunately, when I was in my training in the early 90s, misogyny and the patriarchy were still alive and well. I was just writing about my first night on call where I saw this long-standing, very powerful guy essentially violate a woman while during her delivery, cutting an episiotomy that was inappropriate, not giving her enough pain medicine, screaming at her, strapping her down. I mean, the whole thing was so difficult, awful to bear witness to, and I was helpless. I was an intern. I was my
Yeah.
second night as an intern. I was absolutely helpless, powerless. And that was a big turning point of like, okay, how do I survive this residency? Because this is not going to be the first and only time I see this. Yeah.
Yeah.
Yep.
And I will say I have seen male patients poorly treated by male physicians, all of that crystallizing to me, as well as personal experience as a young female getting health care. And all of that did definitely crystallize a big goal of mine in life, which was to make sure people know I'm on their team. And I think that we as physicians understand that 99% of us are on our patient's team. We want the same things. In my field, we want the cancer gone. We want as little harm as possible from our treatments, as little emotional trauma, and we want to see them well forever and not afraid of the treatment, not afraid of the cancer, and cured, of course. And across all of medicine, whether it's treating hypertension, but I think often it's adversarial or people don't realize we're all want the same thing. And I think that when even myself as a patient, healthcare professional as a patient, anybody realizes that we actually do all have the same goals. And if we take the time to explain that, I think it really makes a difference. And that's always been a goal, male or female, young or old.
Yeah, I think I mean, I've pointed out multiple times on GynoCurious, gender is only kind of part of the formula in finding the right clinician. I've met women physicians who I would want never to have as my clinician, as my doctor. And I've met male doctors who are wonderful. So it's not
Hmm.
just about gender, but it's of the time, contextual, et cetera. So you just mentioned a whole bunch of things that I want to kind of break down. And I guess I want to start with for my own edification, being a radiation oncologist requires an understanding of cancer biology, human physiology, anatomy, technology, quite a lot of different expertise. What was the training like? So you did this internship, and that was kind of a general surgery
Medicine,
internship or general
gym
medicine?
medicine.
Okay. And then I don't know how many years of training do you have as a radiation oncologist?
At this point, it's 4 years
Hmm.
after internship, and most people do an internal medicine internship. And it's really clinic based, but the structure and training also includes the main disciplines of radiobiology, which is a long storied history. And there are PhD radiobiologists, master's radiobiologists who work not just in healthcare, but for things like the US government. And so that's like one domain that we have to get expertise in and be familiar with the literature, from petri dish studies to animal studies to scrutinizing data of clinical trials on humans where the data is just mined for the side effects and reactions of radiation. That field has been around probably since the 50s. Initially, physicians who branched into that, but certainly since the 70s, like a solid career path for biologists. The other domain is the physics. And so typically in our training programs, we interact with the physicists and get lectures and tests just in the radiation physics. And now that a little more enhanced than when I trained. I did my training 93 to 96. But as high-speed computers were just coming on the scene and becoming marketable and usable in our field, because prior to high-speed computers, we knew the algorithms to calculate radiation three-dimensionally, but it would actually take a computer 3 days for the first iteration.
Wow.
And now we do plans that run like 70 iterations in an hour. So very different. But now physics and computer sciences are a big part. And that's been something that every radiation oncologist has had to evolve to. And then, of course, just the clinical of knowing oncology diseases and the cancers and what we need to think about in terms of how to cure them, both historically, and historically is typically research-based, testing this type of surgery versus that type of surgery, this type of surgery plus minus radiation, plus minus chemotherapy, but also the natural history that if somebody has surgery for endometrial cancer, we can look at the clinical details and predict the risk of additional disease in the pelvis and the lymph nodes to decide whether or not a treatment is indicated. So those are kind of the domains, knowing the cancers, which is always evolving the data on that, but to recommend the treatment. And then the radiobiology is kind of the background, kind of like all physicians have a background in organic chemistry and biology, and you may not call to it constantly, but it's always back there. And then the physics and the technology. The laws of physics don't change, but the technology evolves and how to apply them.
Yeah. Thank you. That's helpful. So I have been asked many times over the course of my career when I have made a diagnosis of, let's say, uterine cancer after a surgery or cervical cancer based on a pap smear result or colposcopic biopsies. And my patient will say, I don't want anybody to treat me but you. And my standard answer is there's really, really good science demonstrating that when a woman has pelvic cancer or breast cancer, that they are best off, their prognosis, their treatment plan is best if they go to see a GYN oncologist or a breast specialist. So usually patients are comfortable listening to that and they'll go to see a GYN oncologist. I just want to point out to our listeners, so folks get to see you through the GYN oncologist. Who sends a patient to you?
So it depends a little bit on the disease, but typically it's the oncology surgeon, which could be GYN oncology, breast surgeon, head and neck surgeon for cavity and throat cancers, colorectal surgeon, or the medical oncologist for cases like lymphomas, or sometimes as a multidisciplinary team, we'll have a pattern of referrals. So if we know radiation is going to be indicated, but we know chemotherapy is going to be first, usually the patient will be offered, do you want to see the radiation oncologist now? It will be part of the treatment. It'll be recommended, but we also are recommending chemotherapy, which will go first. And many patients just want to deal with one step at a time. And some patients want to meet everybody up front.
Got it. And when someone comes to see you, certainly I also get that question of like, is radiation therapy scary? How does it go? So why don't we tell everyone what it looks like when someone says to a patient, you need to see Dr. Tapen and she's going to help you go through this radiation oncology treatment. What happens when they arrive at your office that first time, particularly?
Well, I would say prior to meeting me or any radiation oncologist, you should know that typically we spend anywhere from, if it's a straightforward, simple case, 20 minutes to it could be over an hour just reviewing records and details. And there's always, like many aspects of life, a lot of nuances. So sometimes a very complicated case, especially if it's a recurrent cancer, by the time I get records from different facilities, I have to know so many details about what's happened. Even just the first flush, you mentioned endometrial cancer. So now there are so many factors I need to know. How big was it? Where was it? What grade was it? How deep did it invade? Was there lymphovascular space invasion? Margins, P53 mutation, all sorts of prognostic factors that will help me figure things out. As cancer treatments and as the research has blossomed over the past 30 years in oncology, which has made our outcomes so much better in the chemotherapy radiation side, testing A versus B, figuring out the winner, and then B versus C. There's always so many nuances to these trials. And then I have to look at, prior to the patient arriving, I want to make sure that I have the right fit of a recommendation, that that patient really fits into the good outcome of the trial that would spawn the recommendation. Look for reasons that radiation might be contraindicated and or pose a higher risk of side effects, Crohn's disease, and ulcerative colitis if we're talking about the pelvis. And then now, fortunately, there are many computer-based programs where I can put in details of patients' cancers, and it can help me get an accurate estimate on the risk of lymph node disease if we were to do a full dissection, therefore the benefit of radiation. And in breast cancers, there's a lot of, we call them nomograms for different scenarios, and I can put in some details, and it will help affirm, that I can share with the patient, with radiation, the chance of recurrence is this, and without radiation, it's that. And it really helps facilitate the discussion. And that draws in, for 20 studies, 10 studies, that has just made our field so much more complicated, but so much better and so much more appropriately given chemotherapy and radiation, even though we still work off of statistics compared to the 90s, when there is a recommendation for chemotherapy or radiation therapy, the odds of it making a difference of that person living to be a little old lady is much better than it was 30 years ago, where we used very crude factors to recommend chemotherapy and radiation, like breast cancer over 1 centimeter or breast cancer over 2 centimeters. Now we sometimes have 5-centimeter breast cancers and they don't get chemotherapy.
It's you've raised a couple of points that I want to speak to. The first is just a kind of a personal thing, in that I applaud you for doing all this work before a patient even walks in your door. I got to a point in my clinical practice that there were so many no-shows for new patients that I would spend hours cumulatively looking at people's reports, and then they wouldn't show and never show. So I stopped doing it. I said, when a person comes in, then I spend time after their visit, but you can't do that in your field. The other thing is, it's much more really about the individual and in the individual's treatment than, in a way, any other form of care. I mean, chemo, for example, chemo tends to be a bit of a cookbook, certain diagnoses, certain age groups. I mean, there are nuances that change perhaps a dose for one individual from the other, perhaps with the same breast cancer diagnosis. But you are really talking about looking at every detail of a person and her history and determining the right radiation treatment for them or not.
Yes, it's, will it provide a benefit? What are the risks? And then the questions of, what do we treat? Radiation is a physical treatment like surgery. It's a local treatment. It doesn't go throughout the whole body. So then it starts asking, if I'm treating a disease in the pelvis, endometrial cancer, there's standard areas we treat when the nodes are at risk. We know what the echelon, what the pattern of spread is. But I have to make sure, if there's vaginal involvement, there's other lymph nodes I have to worry about, and then taking that all in context. So we have to kind of parse out all those details. And when I meet that person for the first time in the exam room and I'm talking about the side effects, I don't want to have to come back and say, oh, now that I looked at your records in more detail, I realize you are going to get a radiation dermatitis at the groin, because I just quickly looked before. So, and we have a much lower volume of patients. So I would have a busy day for me is 4 consults. And yes, I have
Oh,
no shows, but typically if they don't show that day, they'll show up later. And even if they get rescheduled with my colleague, often we'll pass, I'll write a synopsis of what's important for us in radiation oncology, and we can pass that along. They will still comb through everything. None of us would take each other's synopsis
right,
or
right,
lunch. So that's what happens. And then most of the visit for the first flush when we meet in consultation, many people say, I don't want to go. I'm not sure I want treatment. And the front office staff has to say, you're not getting treatment. You're just meeting to talk about it. Often those meetings last 30 to 60 minutes, sometimes longer if it's complicated. Radiation oncology, I realized early on, is pretty unique because it's not intuitive. Surgery's intuitive. Everybody knows you can get an infection. Everybody can visualize cutting it out and taking it away. Radiation is not intuitive. And I think that we probably spend more time on informed consent than most practices because it's scary. Often people had a grandmother and all they can think about is the dermatitis, the skin reaction that happened, and or the old case scenario that and all physicians know is when we didn't have good CAT scans, much less MRI scans, any screening. It was often thought that when, they opened up the patient surgically and then they closed them up and then the cancer grew so fast, but it's just was a lot of too little, too late. And it wasn't that the radiation or the surgery made the cancer take the person's life quickly in the 1950s. It was that everything was diagnosed just too late.
right, right.
So it's usually a long discussion, and usually I verify the history, a focused exam, and then talking about what will happen with treatment, the logistics, the number of treatments, and going through the side effects in enough detail that I think most of us, but my goal is to be very frank about what the above average side effects are, because everybody would rather be pleasantly surprised. Acknowledge that some people get every side effect early on and it's really hard to manage, but also reassure people that a big part of a radiation oncologist's job is to treat the side effects and mitigate them as best as possible. And that our clinics are designed, we check once a week on patients under treatment at a minimum, more often as needed. Radiation oncology nurses usually can manage most things that come up in the in-between. If they can't, they bring the radiation oncologist in. If somebody needs to be seen every day of the week, that will happen. And, we're in it together. People aren't taking this and doing it at home. Most treatments are in our department daily, Monday through Friday, anywhere from 1 week to 6 weeks. Each treatment is usually just a couple minutes total. Nothing happens. Side effects typically build up over time, very rarely right away. And, most of our offices are open from 7 to 4, 8 to 5, what have you. And so usually there's no surprises and things usually follow a pattern. So usually the first week of treatment, it's notice anything? No. That's what we talked about. Next week's when you should start to notice this. And most side effects in radiation build up slowly. So it gives us time to adjust, whether it's diarrhea, a skin reaction. And I always reassure people, we do a lot of research on managing these side effects. So it's also not just something out of the blue.
And are you modifying perhaps dosage of the radiation when people are having these side effects, or do you stick with if you will, the decision around dosage, and then you just use other modalities to assist in reducing diarrhea or irritation to the skin, etc.?
Yeah. So typically the dose is the dose as prescribed. The data in the clinical trial matches the dose, and we have pretty standard understanding of what dose is needed for microscopic disease, a little different in different types of cancers and very different in the lymphoma family. And then our job is to mitigate the side effects. There are always times that we might adjust the dose a little bit or stretch it out a little bit longer so it's a little bit more gently delivered, depending on somebody's overall medical condition and their ability to tolerate it. And then as we're getting into more often treating octogenarians and nanogenarians, people in their 90s,
Yep.
we wouldn't embark upon a high intensity, high side effect, for instance, treatment of a pelvic cancer lightly in somebody in their 90s. But if they're healthy, we also have to be cognizant that we're not being age biased. And also, it's very simplistic, especially when we're young, to say, oh, they're 90, don't do anything, why make them suffer? But often the disease could pose far more suffering than the side effects of 5 weeks of treatment if we can get it under control or provide a year of control. And so we're balancing those things, but certainly in people who are older, most physicians, most of us understand, and nurses, that a super healthy 90-year-old versus a medium healthy 40-year-old, the stakes are still higher. The body is just more fragile. It's just more likely to have postoperative complications and have a difficult time. That said, many people, get through, but that would be more likely where we might be like, you know what, I feel like we're going to push this too far. Like now our treatment might start to become more dangerous than the disease if we see blood counts drop, if we see nutrition drop. So yes, we should always be mindful if we're ever crossing that line.
Is every patient who's getting radiation therapy, in fact, part of a study?
No.
Okay.
In theory, it'd be nice if everybody was, but realistically, some patients are just not comfortable with that because most clinical trials, you will have additional appointments as the person enrolled in the trial, questionnaires, follow-up, people chasing you down for points of information. Also, most clinical trials, they come in two varieties. There's more than two, but one is testing a new drug for a disease and seeing if it's tolerable and seems to work compared to historical or experience. Those trials are typically for patients who have had recurrent cancers that we don't have other options for. So if that drug ends up being positive, then sometimes people are very lucky to get on those trials. But first flush, if you have a curable cancer, you probably don't want to test a new drug on yourself.
Right.
The more common trial is where we have the gold standard for a given situation, a disease and a stage of the disease, how advanced it is. And we're testing something that's already been preliminarily tested, either in patients who had a recurrence or typically at universities where they start this trial and they say, let's try tweaking the treatment a little bit this way. And some patients are willing to do that. We're trying to lower this more commonly now. It might be a different way of delivering the radiation. We want to see if we believe it's going to be as effective because we've talked about it as a committee. And we think we're going to make the side effect profile better. If that study looks very positive in a university, then we will try and test that against the gold standard. But when a patient gets on that study to test the gold standard against what we hope will be better, they don't have an option of which treatment they get.
Yeah.
And the reason is because we'd be biased and it wouldn't be a solid outcome. And for some people, that's not a comfortable spot. But for many, many people, it is a super comfortable spot.
Yeah. Does everyone get a tattoo when they have radiation therapy?
Good question. Not anymore.
Not anymore.
So most centers do, but there's a new optical guidance system that uses infrared to assess the whole body position.
Wow.
Our tattoos were typically 3 points that were lined up to lasers in the planning room and the treatment room, so that it was our first pass of making sure that people were in the appropriate position, right to left, front to back, not twisted or rotated. And so was historically a great system, but now many centers are moving to an optical guidance system, thereby not needing the tattoos.
Sounds like something taking you to outer space, I tell you. It's
Yeah,
great.
it is. It is.
And has this changed the way brachytherapy or external beam therapy is utilized? And I guess we should articulate how those are different.
Yeah. So brachytherapy is basically seed treatment, something that happens from the inside out. So there are many natural things like cobalt, iridium that are, the word is escaping me, but rocks, if you will, that emit radiation. And sometimes it can be man-made or man-enhanced. And the radiation emitted by these, they're just emitting radiation.
Just
Cobalt's
naturally.
a perfect, yeah, just
Right,
cobalt's a
right.
perfect example.
Yep.
So then we figure out how to put them in little tiny titanium cylinders and either implant them forever and they'll decay slowly and treat the cancer, much more common in prostate cancer, not applicable to women. For women, more commonly, it is metal cesium that is encased that for particularly cervix cancer can be placed right next to the cancer, the cervix being donut shaped right in the middle of the donut and around the donut. And this type of radiation doesn't travel or penetrate very deeply, but can be really instrumental in treating from the inside out. The daily treatment we do typically is where you lie on a table and a linear accelerator moves around you and the x-rays come from outside in. We cannot change the laws of physics. They go through the body. We can modulate now and really paint the dose very fancy, but external radiation has to pass through intestine, which is probably the most sensitive structure in our pelvis. Using a combination of treatment coming from the outside and then putting these seeds next to the cervix for 10 minutes or 15 minutes a couple of times, we can get a combination of radiation that respects the safety limit of the intestine and the rectum and the bladder and tremendously enhances our cure rate when we cannot do surgery for cervix cancer. And so it's a combination of those. That treatment always sounds very barbaric to people, but
I remember seeing it done. Oof.
yeah.
Yeah.
One thing that's changed now most commonly is most of those procedures are with sedation because we need everything positioned better and insurance companies have come around to paying for it. And I think 98% of women after these procedures say, oh, it was so much better than I thought it would be. And, it was awkward, uncomfortable, but it was, and nobody likes to have stuff happening between their legs medically, but they get through it.
It's you might need to correct me, but when I trained again in the 90s, I remember going to Hershey, PA for GYN onc, and a woman was diagnosed with cervical cancer, an advanced stage. And these were the days where we saw cervical cancer much, much, much more often than we do now, with not only with PAPs, but HPV testing and the understanding of the HPV virus and its impact on the cervix. We actually see very little cervical cancer in this country. But I remember this woman getting the tandem and ovoid procedure, and she had to stay in the hospital for days. Is that still
No,
the case?
no. So,
okay.
so that was how it used to be done with cesium.
Mm.
And a woman would be hospitalized and in bed, and it would be for anywhere from 24 to 36 hours to slowly let the radiation emit itself. Now it's almost exclusively delivered with iridium, which delivers the radiation much faster. So we call it high dose rate. And typically the procedure is done where it used to be the tandem and ovoid was placed once and you were in the hospital for 2 to 3 days, depending upon the calculations. Now it's 2 to 5 times, depending a lot on there's a lot of details, but you would come in once a week. The tandem and ovoid is placed. Now a CAT scan is done to calculate. And then a single radiation seed is by a robot sent up to the tandem and ovoid. and it goes to one ovoid, dwells, comes out, goes into the tandem, dwells in
Wow.
different positions. That whole procedure typically takes 5 minutes to deliver the radiation. The high dose rate is pretty hot, so I never would deal with that or touch that. I'm always in a different room, whereas in the low dose rate, the physicians would handle the sources, load them, place them, check on the patient, be in the room, remove them. The high dose rate happens so fast that staff cannot be exposed to it. But it
Yeah.
is much more comfortable, lower risk of, being in bed for 24 hours, 36 hours is not safe medically.
Yeah.
And you don't feel the radiation when it happens. And typically you're sedated in the OR. The tandem and ovoid is placed while somebody's relaxed. You wake up, the CAT scan's done, everybody's working as fast as possible. Calculations are done. Then the tubes get hooked up, which doesn't hurt because they're not your body. The treatment happens, and then things coming out is much easier than things going in. And so then they just slide out and you're done, and then repeat again a week later.
Yeah, thank you. Thank you. So, for those of you who are listening, this is complex science. This is not, as Beth has pointed out, it's really clear to us what it means to have surgery. Something's cut out. With radiation oncology, it's a complex formula. It sounds like, thank goodness, the science has really evolved over the last couple of decades, where not only is the impact on women gentler, easier, but more effective. And this is always what you want to hear about science, and particularly the healing modalities that we use. And do you think that radiation is always going to be a part of cancer healing? Does it feel like it's becoming less and less a part of cancer healing, or no real shift?
I do think it is. There's always a little, we would hope that immunotherapy, maybe we'd get to some kind of immunoprevention. Personally, I think every oncologist would be happy to be out of business if we can have something, and none of us or our family have to be thinking about having our breast removed, our colon removed,
Yeah.
and much less chemotherapy and radiation. That said, I think that we'll always be there, but how we get utilized has changed dramatically, from cervix cancer being a common part of practice to not being a common part of practice, not because our treatments have improved, but because early detection has improved and the vaccination. But we will continue to evolve. And there is, breast cancer led the way with the concept of organ preservation, that can we not do a radical mastectomy? Is the disease really just local, or is it systemic? And how can we tailor treatments so that we're doing just what we need? And breast cancer history is being repeated in colorectal cancer, which affects many, many women. And figuring out, we want to get rid of course, of rectal cancer, but we all want to have a functioning rectum and anus for the obvious reasons. So I think it'll change. And rectal cancer, colorectal cancers being the third most common cancer in women, is worth a mention, but there's been this competing research in avoiding radiation and avoiding surgery. Can we get to two treatments, chemotherapy and surgery, or chemotherapy and radiation versus all three? And right now, radiation is winning, and we're finding success in what we call non-operative management, that actually with intensified chemotherapy and radiation, the long-term quality of life is better than having part of the rectum removed, because it doesn't function as well as you would want it to.
Yeah.
But in a couple years, there's research cooking that it could flip the other way. So we don't know.
Yeah.
But research really has been a key. And one thing I would like to say to the listeners is always be open-minded about clinical trials. It can bring a lot of gratification that you are serving women in the future get a better treatment, and people find a lot of gratification in that. And early in my career, I was moved by following the history of breast cancer research. And while the researchers were really important, it was the thousands of women across the globe who were willing to say, I will be randomly allocated to having my breast removed or having the cancer removed and following with radiation, or just having the cancer removed without radiation. And it may be that one of those treatments is less curable, one of those treatments is more curable, and one of them may have worse side effects. And I look back to the 70s when brave women, against their husband's advice, their primary care doctor's advice, usually against the general surgeon's advice, were willing to enroll on those studies and really change the world for women going forward.
Yeah.
And I
Yeah.
think we often forget about the service of people who enroll in clinical trials.
Yeah. And what I would also say and encourage our listeners to remember, and I've said this many times on GynoCurious, find the right doctor to work with. You want to, if you're thinking about a trial, but you want a very thorough, informed consent, you don't go to someone who hands you a piece of paper and says, sign it. You go to the person who literally goes line by line and reads it with you, just explains it to you, takes things from medicalese and translates it to, everyday English, because you want to be as informed as possible, not only about risks and benefits, but side effects, duration, everything about the treatment, like any other treatment. And you have the not only the right, but in a way, a responsibility to your body to demand that. I think I said more recently on a show, I used to go, I still go line by line, and women would say, no one has ever done informed consent like that with me. And I'm like, I'm not just protecting you, I'm protecting me too. And that I want you to go into that OR as informed as possible. One, because I think you heal better and our relationship stays intact. And that's so, so important to me. And it certainly sounds like you do that each and every time with your patients. So I want to just, applaud you for your heart and the mind that clearly goes into this kind of work. Yeah. Thank you. Thank you.
Oh, it's a joy. I mean,
Yeah.
it's not a joy to see what the world hands us sometimes in illness, but it's a joy to be there to hopefully not just do the right technical treatment, but to make it easier along the way. And then in the future, because people's bodies aren't the same after our treatments, to have them not look back and say, maybe I shouldn't have done it. I mean, I think that you want to be cured and you want to go on. And if you have a side effect, you want to think, I looked at all my options, I made my decision, and, I can't say I wasn't informed or I knew this was a possibility. Not that you shouldn't be remorseful if you have something that you have to live with in the long term from surgery, radiation, or chemotherapy. But we try and be frank. There's no miracle cures, but we're trying to make it as safe as possible. But the people who have something that comes up, usually serious long-term complications from radiation treatment, if it's over 1%, we consider that high, and that's not a standard treatment. Something that
Wow.
would require intervention, surgical intervention. Now, things feeling different in your body that don't require medical treatment and don't pose a health risk, don't require medication or surgery or change your ability to work, that happens more commonly. But something that would require a surgery to correct, a medicine, keep you from doing your job, keep you from traveling, keeping you from doing what you want to do, those are typically pretty uncommon. And most of us, there are diseases where we will accept a higher rate, but we'll usually say, and I think cervix cancer is a good example, when we put all that radiation inside, the rectum really is right there. And there we will see a 5% incidence of rectal bleeding that could require rectal steroids, cauterization, probably 1% that is surgical intervention, but we'll usually go over that with people.
Yeah. Yeah. Good. 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 All right. So for those of you listening out there, this doesn't have to be scary. It doesn't have to. It just requires information. It requires conversation. It requires patience. I like to say to folks also that if you decide to do radiation, guess what? You can always say to someone like Beth, I'm not completing the course. I'm done, or whatever, that there's always room for changing one's mind. So know what your options are. So we are coming to an end. And Beth, I'd like to end the conversation talking about when you're not working. What do you do for pleasure? What do you do so that you make sure you stay well and healthy and fit in mind and body for the work that you do?
Um, in the winter, I ski, and in the spring, summer, and fall, I think about skiing.
That's
And
great.
a little bike riding in the summer. And I think that the joy of speed, and speed is a relative term. I'm not a ski racer. I'm a pretty old woman who does not want to have a fracture. But the wind in your hair, the strength to control it, you you don't think about getting hurt when you're in the moment. And I think that's underrated. And somewhere along the line, I realized that probably girls and women need to keep some speed in their life.
I hear you. I totally agree. So to all of us, may we find a way in which to have some wind in our hair.
Yeah,
It's a good thing. Thank you for joining me today, Beth.
my pleasure. My pleasure.
And thank you to my co-producers, Jen Hammoud and Maddie Rosenberg. Until our next episode of GynoCurious, please stay well. Listen to your instincts and intuitions. They are the greatest of teachers, not to be ignored. Be well.